Ladies and gentlemen, thank you for joining the Lake Superior Quality Innovation Network. Tips for utilizing preventative services. Your host for today is Michelle Dewey. Please begin.
Good afternoon and welcome to today's webinar presented by Lake Superior Quality Innovation Network. Lake Superior Plan is comprised of three organizations: MPRO in Michigan, Metastar in Wisconsin, and Stratus Health in Minnesota, to support the Centers for Medicare and Medicaid Services priorities for healthcare quality improvement in each organization's respective state. Today's webinar slides will be available on our Lake Superior Quinn YouTube page within the next week. They are also available on the login page. Today we will be talking about preventive services that you may be able to apply in your practice. This information is intended to serve as a general reference regarding reimbursement. You are responsible for submission of accurate claims and any part documentation audits that may occur. First of all, I'd like to let you know that the information provided in this presentation is based off of CMS-provided tip sheets. We will post the link to these tip sheets within the chat section of the presentation. At the end of this presentation, you will be able to understand the opportunities for diabetes self-management, which includes screening, self-management training, and medical nutrition management. You will also have the knowledge to implement a process to provide additional services for your Medicare patients. These include the initial preventive physical exam, the annual wellness visit, and intensive behavioral therapy for obesity and cardiovascular disease. We will also review the 5A framework, which is an effective approach for successful intervention. We will start our presentation today with diabetes and pre-diabetes screening. The goal of any screening is early detection and prevention of disease. Now I will turn it over to my colleague, Tisha Looper, who will discuss diabetes screening opportunities.
Thank you, Michelle, and good afternoon to everyone. As Michelle stated, the first tip sheet we'll be reviewing is the diabetes and pre-diabetic screening, specifically looking at pre-diabetes glucose screening first. In order for a patient to be eligible for pre-diabetic glucose screening, they must have been diagnosed with at least one of the following: pre-diabetes, which is defined as having a fasting glucose of 100 to 125 or 140 to 199 on a 2-hour glucose challenge. They could also have hypertension, dyslipidemia, or obesity, which is having a BMI of over 30 or higher. If none of these conditions have been diagnosed, the patient is eligible if they meet two of the following: if they're over the age of 65, if they're overweight, which is meaning they're defined as a BMI of 25 to 29, have a family history of diabetes, meaning a sibling or a parent, and or have gestational diabetes or delivered a baby greater than 9 pounds. Patients diagnosed with prediabetes can have this screening every 6 months. Those without prediabetes diagnosis can be screened annually, and as long as they meet the eligibility requirements that I just discussed. So if you're able to draw the following glucose labs in your office, here are a few of the codes that you'll have to use. Or if you don't have the capability to draw these labs in-house, these codes will also pertain to you if you will be ordering the lab work through your local lab. So please note that the screening is not covered if the Medicare beneficiary already has diabetes. If the patient meets the eligible criteria, the copay and deductible do not apply to these tests. For the ICD-10 code that you're going to use, it will be the D1 3.1, and this code is the actual code for encounter for screening for diabetes mellitus. Our next slide is diabetes, the next tip sheet is diabetes self-management training, or DSMT. The goal of DSMT is to educate the patient in successful self-management of diabetes. Areas of training include self-monitoring of blood glucose, overall diet concepts, exercise guidelines and techniques, medications, complication prevention, problem solving, and coping and motivation. These behavior change goals are individualized to meet the patient's lifestyle and clinical targets. Training classes can be held at a variety of locations, including healthcare facilities such as outpatient departments, skilled nursing facilities, and independent clinics, and at community sites such as schools, libraries, or senior centers. Please note that DSMT will not be covered if held in a non-skilled nursing home, hospice care, ER, or other hospital inpatient care. So you may recognize two names of the self-management program, DSME and DSMT. DSME, which is Diabetes Self-Management Education, and DSMT, Diabetes Self-Management Training, these offer the same education to the participants. However, the only difference is that the DSMT is a Medicare term for reimbursable DSME. If you do not have a diabetes educator in your office, you cannot bill for DSMT services. If you want to know more about how you can be certified, please go to the AADE website, which is the American Association of Diabetes Educators, to find out more. The DSME is a free program taught by lay educators, so they do not have to be certified like the DSMT. To find out more about DSME classes in your state, contact your CLIN, which that is MPRO for Michigan, Medi-Scout for Wisconsin, and Stratus Health for Minnesota. And at the end of this presentation, we will have the contact information for each state. So if you do have a certified diabetic educator, please take note of the following. In order to be eligible for DSMT, the patient must have a diagnosis of type 1 or type 2 diabetes. Unlike the blood work that we previously, or the blood work screening that we previously discussed, prediabetes does not count for DSMT. Initial training does not exceed a total of 10 hours. So this can be done in any combination of half-hour increments and spread over a 12-month period. Initial DSMT is a once-in-a-lifetime benefit, and follow-up DSMT in succeeding years does not exceed 2 hours, which these also can be done in half-hour increments over the course of 12 months. So for those of you who do not have certified educators to the program, DSMT services, you can definitely refer your diabetic patients out to a local DSMT class. DSMT must be ordered by a physician or non-physician provider, which would be a PA, NP, or clinical nurse. And you can check out your state's website for a list of accredited DSMT program locations that you may refer your diabetic patients to. If you do have a certified diabetes educator in your practice, you would like to begin implementing DSMT classes, here are the appropriate billing codes that you will need. ICD-10 codes range from E08 through E13 and O20 to O29. Your HIPPE codes include G0108 for an individual session, or you can do a group session, which is G0109. Please note also for this, Medicare co-pays and deductibles do apply to DSMT services. And then also an extra note, if you are practicing in an SQHC or federally qualified health center or a rural health clinic, only individual DSMT, which is the G0108, can only be billed. You cannot do group sessions for SQHCs or RHCs. Okay, and the last tip sheet that I will be going over is the medical nutrition therapy, the MNT tip sheet, which is actually on the back of the DSMT tip sheet. The goal of the MNT is to provide diet therapy and or meal planning tailored to the patient's condition. It is a more in-depth diet therapy compared to the general concepts of the DSMT classes and includes monitoring the patient's labs over time. It can be used before or after DSMT, but cannot be used on the same day as the DSMT class. Medicare beneficiaries can be referred by their physician to MNT if they have a diagnosis of diabetes, pre-dialysis renal disease, or if they've had a successful kidney transplant within the last 3 years. Documentation supporting these diagnoses must be in the patient's medical record, and MNT is not covered for patients with pre-diabetes, so it is only your diabetic patients only. Medical nutrition therapy must be performed and billed by a registered dietitian or by a nutritionist with a Bachelor of Science in Dietetics. Patients can receive 3 hours of one-on-one or group counseling in the first year and 2 hours per calendar year thereafter. So if you're eligible to actually complete the MNT therapy or medical nutritional therapy in your practice, here are the codes, which must be billed by the appropriate provider as mentioned in the last slide. These services are more than likely going to be referred out unless you have a qualified provider in your office. So, now I'll turn it back over to Michelle to discuss preventative and screening services that actually you should be able to bill in your practice.
Thank you, Keisha. Okay, the first billable service that we will talk about is the initial preventive physical examination. This is commonly referred to as the IPPE or the Welcome to Medicare visit. This is a one-time benefit that must be performed within the first 12 months of the Medicare Part B coverage period. The goals of the IPPE are health promotion and disease prevention and detection. The Welcome to Medicare visit is not a routine physical checkup. It is an introduction to Medicare and the covered benefits. A list of the Medicare Part B preventive services can be found on the CMS website, which is provided for you in the chat section. The components of the IPPE are easily explained by using the ABCs of the Welcome to Medicare visit. They include A, acquire patient information, which consists of the patient's medical and social history. This includes past medical and surgical history, current medications, including vitamins and over-the-counter treatments, family history of tobacco, alcohol, and drug use, diet, and physical activity. It also includes the patient's potential risk for depression and other mood disorders. There are several screening tools that can be used to detect these disorders, such as the PHQ-2 or PHQ-9. Lastly, you'll need to obtain the patient's functional ability and level of safety. This can be done by using appropriate screening questions to review hearing impairment, daily activities, fall risk, and home safety. Next is B, begin examination and discussion. The required elements of the exam include height, weight, BMI, blood pressure, and a visual acuity screen. Also, on agreement of the patient, end-of-life planning may be discussed. Another option is to provide the patient with written information regarding an advance directive, such as a pamphlet or a printout. Lastly is C, counsel the beneficiary. Based on the results of the review and evaluation, the patient may need further education, counseling, or will need to be referred to a specialist. It is also required to provide a brief written plan or a checklist for the patient to obtain appropriate screening or other preventive services. Examples of these include a mammogram, colonoscopy, and vaccines. Again, for a list of other Medicare-covered preventive services, please reference the list on the CMS website. Here are the appropriate codes to use when billing the IPPE. Performing and billing an EKG is recommended but is not required. Medicare waives the coinsurance and deductible for the IPPE, which is the G0402. However, it is not waived for the screening EKG. And please note, with all payouts, the amount of reimbursement can vary depending on geographic region, as well as on negative adjustments due to non-participation of PQRS and the EHR incentive program. Since CMS does not require a specific diagnosis code for the IPPE, you may choose any appropriate diagnosis code. A diagnosis code must be reported, and neglecting to provide a diagnosis code will result in a rejected claim. Medicare covers an IPPE when performed by a physician assistant, a nurse practitioner, or a certified clinical nurse specialist. If the patient is being seen for something else at the same time, and you need to use an E&M code, just make sure if you use a modifier 25. Next is the annual wellness visit. The annual wellness visit is very similar to the IPPE, but it goes into more detail. This can also be fulfilled by using the ABC model. Like the IPPE, you will begin the initial annual wellness visit by acquiring the beneficiary's information. At a minimum, the health risk assessment must consist of demographics, a self-assessment of health status, psychosocial risks, behavior risks, daily activities like dressing and bathing, and instrumental activities of daily living, such as shopping and handling finances. You will then need to collect and document the following: what specialist the patient sees, medical and family history, potential risk factors such as depression, and safety level, like fall risk. The next step, you will begin the assessment, which includes height, weight, BMI, and blood pressure. You will also want to observe the patient's cognitive function and take into consideration any reports or concerns raised by family members or caretakers. Lastly, you will counsel the beneficiary by providing them with a list of age-appropriate preventive screenings that are recommended, and also discuss any treatment options that may be necessary if there are any risk factors. If necessary, referring the patient to counseling programs or health education, such as tobacco cessation or nutrition classes, can be established at this time. Once the initial annual wellness visit is complete, the patient should be seen annually to update the information collected in the annual wellness visit. The subsequent annual wellness visit, the ABCs will again be used, but will most likely consist of updating the patient's record. The initial annual wellness visit cannot be performed and billed within the first 12 months of the patient's Part B Medicare coverage, and cannot be done within 12 months of the IPPE. The annual wellness visit in subsequent years must be at least 12 months after the initial annual wellness visit. The copay and deductible do not apply to these visits. When billing for the annual wellness visit, you will need to use G0438 for the initial visit and G0439 for subsequent years. Any appropriate ICD-10 code can be used. If necessary, an E&M may also be billed with the modifier 25, but would be applied to the patient's copay and/or deductible. Another preventive service that can be offered to your patients is intensive behavioral therapy, or IBT, for obesity. The goal is to provide the patient with intensive behavioral exercise and diet interventions to promote sustained weight loss. Evidence concludes that IBT for obesity is necessary for the prevention and/or early detection of illness or disability for patients. The two requirements for patients to be eligible are, 1, having a BMI of 30 or more, and 2, be competent and alert at the time that the counseling is provided. The content of this therapy includes an obesity screen by using the BMI, dietary or nutritional assessment, and intensive behavioral exercise and dietary interventions to promote sustained weight loss. Examples of interventions include having the patient eat slowly, having the patient record their meals, and having the patient seek social support from relatives, friends, or clubs. The intensive behavioral intervention for obesity should be consistent with the 5A framework, which will be discussed later in the presentation. Physicians of family practice, internal medicine, OBGYN, pediatrics, and geriatrics are eligible to perform and bill for IBT for obesity. Nurse practitioners, clinical nurse specialists, and physician assistants are also acceptable. Beneficiaries with obesity can be seen once a week for the first month, once every 2 weeks for the following 2 to 6 months, and then once a month for the remaining 6 months of the 12-month period. However, at the 6-month mark, there is a weight loss requirement of 7 pounds. If this requirement has not been met, then a reassessment of the patient's readiness to change must be discussed. Patients can receive therapy up to 22 times per 12-month period, and if they are still obese at the end of the year, a new order can be generated. Here are the diagnosis codes and procedure codes for IBT for obesity. This can be billed at the IPPE visit or with the annual wellness visit, but not with any other preventative care service. Also, it cannot be billed on the same day as DSMT or MNT. There is no copay or deductible to the beneficiary. The billing code is to be used at each IBT visit, and reimbursement can range from $24 to $27. Our last tip sheet is intensive behavioral therapy for cardiovascular disease. The goal of this is to provide counseling for aspirin use and promoting a healthy diet. Medicare recommends that all men aged 45 to 79 and all women aged 55 to 79 receive this therapy once a year. There are 3 parts to be discussed at the visit. First, encourage aspirin use as appropriate, screen for high blood pressure, and intensive counseling for those with cardiovascular risk factors. As with IBT for obesity, the 5A framework, which consists of assess, advise, agree, assist, and arrange, can be utilized to achieve IBT for cardiovascular disease. The eligible providers who can bill for IBT for cardiovascular disease are the same as the IBT for obesity, but the frequency for this service is once a year. The billable code is G0446 with any appropriate billable diagnosis code. It can be billed on the same day as the annual wellness exam or the IPP, and the copay and deductible do not apply. That concludes our tip sheet. So now we will talk about how you can increase these services for your patients. We recommend running a gaps in care report from your EHR or registry. So for example, if we want to see who can benefit from a prediabetes blood test screening, you would pull a report of your Medicare beneficiaries who meet one of the eligible diagnoses. Once the population has been identified, then you are able to contact your patients and set them up for an appointment or provide them with a lab order. Having an office champion who takes responsibility for identifying patients that are due for services is a good way to ensure that these reports are done on a monthly basis. Other opportune times to check for services that are needed are prior to a visit, at check-in, or at checkout. Creating standing orders can also help with an efficient workflow that will increase screening rates. And with any new process in your office, it is very important to have a strong support and encouragement of your physician. So as I mentioned before, using the 5A framework is an effective way to achieve the requirements for intensive behavioral therapy for obesity and for cardiovascular disease. This method can also be used in other areas, such as tobacco cessation. There are 5 major steps for this intervention: assess, advise, agree, assist, and arrange. An example for using the 5A framework for IBT for obesity would be you would first assess, so you would assess the patient's health status and BMI, and then ask the patient if it would be okay to talk to them about their weight. Then you would advise the patient about the risks of obesity and explain the benefits of modest weight loss. At this time, you can discuss options and talk about an action plan. The agree step is about respectful negotiation in goal setting and behavior modification to achieve weight loss. For the assist step, the clinician's role would be to identify, educate, and recommend areas of support, such as counseling. Lastly, you will need to arrange a follow-up visit. This will keep the conversation going and help with motivation and support. Here's a list of some of the resources that we mentioned earlier in the slide. And then a list of our contacts if you are interested in DSME or DSMT. Okay, so today's slides will be available on our Lake Superior Quinn YouTube page within the next week. And at this time, let's pull up the evaluation questions. And if you could please take a moment to let us know how we did by filling these out. And operator, can we open the lines for any questions?
Ladies and gentlemen, if you have any questions at this time, please press the #1 key. Again, if you have any questions or comments at this time, please press the #1 key. And Michelle and Tessa, I'm waiting for people to join the queue, please. We have a question from Michelle Blair from Prairie Ridge Hospital. Please go ahead.
Hi, my name is actually Courtney. I'm a nurse practitioner here. I had some questions about the Welcome to Medicare visit as well as the annual wellness visit. So, I mean, these patients with multiple chronic health problems, are we supposed to have them come in for a completely separate visit, or how are we supposed to bill that?
You would be able to bill the E&M code as well, along with the annual wellness visit or IPPE.
Okay. Well, I'm just thinking, I mean, a lot of these patients, if they're coming in and say they have, hypertension, hyperlipidemia, CHS, a lot of these other things, they want to, they have questions about all of these type of things. So I'm wondering, if I order lab work and do a lot of extra stuff, so I can bill for that all separately?
Yep, as long as you use the modifier 25, it would go on the same claim.
Okay. So they would just get billed for everything separately. Okay. I just didn't know if I could do that in the same visit or if that has to be separate from their annual wellness visit.
No, it can be done in the same visit. As long as you use the appropriate diagnosis code and you're using the modifier 25, and then just know that if there's a copay or deductible, the patient would be billed for that portion of the visit.
Okay.
Again, ladies and gentlemen, if you have any questions at this time, please press the #1 key. Again, if you have any questions at this time, please press the #1 key. Tisha and Michelle, I don't have anyone in the queue at this time.
Okay, well, if there are no other questions, thank you for joining us today for the tips for utilizing preventive services. And as a reminder, the slides will be available on our Lake Superior Quinn YouTube page within the next week.
Thank you, ladies and gentlemen, for joining. This completes your conference call. You may all disconnect, and I hope you have a great day.